Welcome to the Week in Diabetes and Endocrinology from Hormone Insight. This podcast delivers a summary and perspective on the top news of the week that endocrinologists, diabetologists, and internists can't afford to miss. This podcast is intended for healthcare professionals. For the week ending April 3rd, 2026, I want to talk about Orforglipron, the oral GLP-1 pill that just got approved, and why I think the hype is outrunning the data, the new higher dose Semaglutide 7.2 mg injection, and a side effect signal that I think deserves way more attention than it's getting, once weekly basal insulin, which sounds great until you think through the pharmacokinetics. A JAMA Cardiology Post-Hoc of SURPASS-CVOT that's actually pretty compelling. The new AACE type 2 diabetes algorithm, and a meta-analysis that should make us all pump the brakes on GLP-1 receptor agonists in Parkinson's disease. Let's get into it. Alright, let's start with the big one. On April 1st, and yes, April Fool's Day, but this is legit, the FDA approved Lilly's Foundayo, which is Orforglipron, the first oral non-peptide GLP-1 receptor agonist for chronic weight management. And look, the coverage of this has been breathless. Game changer. The pill that could replace Ozempic. You've seen the headlines. So let me cut through the noise and tell you what I think actually matters here. The pharmacology is genuinely interesting. Orforglipron is not a peptide. It's a small molecule, about 500 Daltons, that works as a positive allosteric modulator at the GLP-1 receptor. That's different from semaglutide, which is a 39 amino acid peptide that has to be co-formulated with this absorption enhancer called SNAC just to get across the stomach lining. And even then, the oral bioavailability of semaglutide is somewhere around 0.5% to 1%. That's why you have to take Rybelsus fasting with barely any water and wait half an hour. It's a hassle. Orforglipron? None of that. Take it anytime, with food, with coffee, with water, doesn't matter. And for patients, that's a real practical advantage. I don't think we should underestimate how much those fasting restrictions affect real-world adherence. But here's where I want to be straight with you. The weight loss numbers from the ATTAIN trials, and there were 2 pivotal phase 3 trials with over 3,000 patients, are good. They're not great. At the highest dose, 36 milligrams, patients lost about 11% of their body weight over 72 weeks. Placebo group lost about 2%, so the placebo-subtracted loss is around 9%. Now, 9% placebo-subtracted is clinically meaningful, absolutely. That's enough to improve sleep apnea, improve fatty liver, improve glycemia. The FDA's threshold is 5%, so it clears that. But let me put it in context. Tirzepatide, injectable, gives you over 22% in SURMOUNT-1. Semaglutide 2.4 milligrams injectable gives you about 15%. The new Semaglutide 7.2 milligrams gives you nearly 21%, so Orforglipron at 11%? That's in the same ballpark as Liraglutide 3.0, which we've had for years. So what you're really getting with Orforglipron is convenience, not potency, and there's nothing wrong with that. But we need to set expectations. If your patient is BMI 42 with obstructive sleep apnea and severe knee osteoarthritis, and they need to lose 60 or 70 pounds to get to surgery, Orforglipron probably isn't going to get them there. They need an injectable. But if your patient is BMI 33 with prediabetes and mild MASH on ultrasound and they've told you flat out, I am not doing an injection, then Orforglipron is exactly the right drug. The GI side effects are what you'd expect. Nausea in about a quarter to a third of patients. Treatment discontinuation in 5 to 10% versus 3% placebo. The dose titration, 6 steps from 0.8 up to 36 milligrams, helps with tolerability, but there's no getting around it. GLP-1 agonists make some people nauseated. That's biology, not pharmacology. 2 more things I think are worth flagging. First, the approval speed. This was the first new molecular entity cleared under the FDA's Commissioner's National Priority Voucher Program. 50 days from filing to approval. That's the fastest for a new molecular entity since 2002. And I know that's partly because the data were clean and the obesity need is real. But I also know there's an enormous amount of commercial pressure in this space, and 50 days makes me wonder whether we'll look back in 5 years and wish we'd taken longer. Second, and this is important for those of us who practice internationally, especially in the Middle East and South Asia, where type 2 diabetes and obesity rates are staggering. An oral small molecule without fasting restrictions and without cold chain storage requirements is potentially transformative for access. Injectable GLP-1 RAs are out of reach for most health systems in low and middle income countries. If Orforglipron can be manufactured at the kind of scale and cost that small molecules typically achieve, the global health equity implications are significant, and the US pricing, $149 to $349 a month cash pay, is a fraction of what Wegovy costs. That matters. Bottom line on Orforglipron, it's a welcome addition. It's not a replacement for injectables when you need maximal weight loss. Know the numbers, set expectations, and don't let the headlines tell you this is a game changer. It's an access changer. Sticking with obesity pharmacotherapy, hard to avoid it right now. On March 19th, the FDA approved Wegovy HD, which is semaglutide 7.2 mg subcutaneous once weekly. That's 3 times the dose of standard Wegovy. And the step-up data are impressive. In adults with obesity and no diabetes, mean weight loss was 20.7% at 72 weeks. About 1 in 3 patients hit 25% or more. In the type 2 diabetes trial, 14.1%, which, by the way, is about what semaglutide 2.4 achieves in people without diabetes. So this higher dose essentially overcomes the diabetes weight loss penalty that's been the bane of our existence with incretin drugs. Okay, so far so good. But here's the thing that's bugging me, and I haven't seen enough people talking about it. Dysesthesia, altered skin sensation, tingling, numbness, burning. At the 7.2 mg dose, 22% of participants reported it. 22%. Compare that to 6% at the standard 2.4 mg dose and 0.3% on placebo. That's a big dose-dependent signal. And we don't fully understand the mechanism. There are a few possibilities. 1. Rapid weight loss itself causes compressive neuropathies, meralgia, paresthetica, carpal tunnel. That's well described after bariatric surgery. 2. There's preclinical evidence that GLP-1 receptors sit on dorsal root ganglion neurons, and at these supraphysiologic doses, you may be directly altering peripheral nerve excitability. 3. Vitamin B12 deficiency. We already know metformin lowers B12. GLP-1 agonists reduce gastric acid secretion, which impairs intrinsic factor B12 absorption. At these higher doses, that effect could be magnified. So, what am I doing in practice? If I'm writing for semaglutide 7.2, I want a baseline B12 and methylmalonic acid level. I want to ask about pre-existing neuropathy, and I'm telling the patient, if you get new tingling or numbness in your hands or feet, call me right away. Don't just assume it's nothing. And I'll say this, in patients with type 2 diabetes who already have subclinical diabetic peripheral neuropathy, and that's a lot of patients, I'm genuinely uncertain about layering on a drug that causes dysesthesia in 1 in 5 people. We need more data on that specific population, and we need it urgently. The bigger strategic question, is tripling the dose of a single drug the right approach, or should we be combining lower doses of agents that work through different pathways? I think the field is headed toward combinations. CagriSema, cagrilintide plus semaglutide, is in phase 3. Survodutide combines GLP-1 with glucagon receptor agonism. If these combinations can deliver 22 to 25% weight loss at lower semaglutide doses with less dysesthesia, that's a better drug. And I think that's where we'll be in 3 to 5 years. Bottom line, semaglutide 7.2 is a powerful tool. The weight loss is real, but the dysesthesia signal is real too. Check B12, monitor nerves, and ask yourself if your patient really needs the high dose, or if they do just as well on 2.4 with realistic expectations. Let's shift away from GLP-1s. On March 26th, the FDA approved Awiqli, insulin Icodec, the first ever once-weekly basal insulin for type 2 diabetes. And I get the appeal. I really do. 1 injection a week instead of 7. For a patient who's missing 2 or 3 daily doses a week, and the adherence data tell us that's at least a quarter to a third of patients on daily basal insulin, this is a no-brainer, right? Well, maybe. Let me walk through the data and then tell you what concerns me. The Onwards program had 4 pivotal phase 3 trials, about 2,680 patients. Onwards 1 compared Icodec to glargine U100 in insulin-naive patients on oral agents. The headline, Icodec was non-inferior and statistically superior for hemoglobin A1C reduction, with a treatment difference of minus 0.19 percentage points. And on CGM, the time in range was about 72% for Icodec versus 67% for glargine, a 5-point advantage. Now, 0.9% in hemoglobin A1C doesn't sound like much, and in a treat-to-target trial design where both arms are titrated to goal, it shouldn't be much. The real story here is adherence. In a clinical trial where nurses are calling patients every week to titrate their insulin, of course the results are similar. In the real world, where patients are on their own, that's where once weekly should shine, and we need the real-world effectiveness data to prove it. But here's where my inner pharmacologist gets nervous. Insulin Icodec has a half-life of approximately 196 hours. That's over 8 days. It works through very strong albumin binding. The drug circulates bound to albumin and slowly releases active insulin over the week. So think about this scenario. Your patient, let's say a 72-year-old man with type 2 diabetes, eGFR of 38 on Icodec 700 units weekly, gets gastroenteritis, vomiting, diarrhea, can't keep food down. With glargine, you tell him to hold his dose, and within 12 to 24 hours, his circulating insulin drops meaningfully. With Icodec, there is no holding the dose. The insulin depot is already in his subcutaneous tissue and bloodstream, bound to albumin, and it's going to keep releasing for days regardless. You've got a week's worth of insulin on board that you cannot take back. That's a fundamentally different sick day problem, and the prescribing information addresses this, but I don't think most clinicians have fully internalized it. Severe hypoglycemia in the Onwards trials was numerically similar between Icodec and glargine, but the trial populations were carefully selected. I worry about what happens when this drug gets to the broader population, the frail elderly, the CKD4 patients, the patients with unpredictable oral intake. There's also the loading dose issue. Because the half-life is a week, it takes about 5 weeks to reach steady state. Novo Nordisk recommends a 50% loading dose for the first 3 injections. If you don't load, your patient may be undertreated for a month after initiation or switch. That's a teaching point that's going to get missed by a lot of prescribers. Now, here's the flip side, and it's a big one. For patients in the Gulf, in South Asia, in Southeast Asia, wherever Ramadan fasting affects a large part of your practice, once weekly insulin is a major practical advance. Daily insulin timing during Ramadan is one of the most challenging aspects of diabetes management in these populations. A single injection on the same day each week, regardless of fasting, simplifies things enormously. That alone makes this drug worth having. And I'll say one more thing. Once weekly insulin may actually change how we initiate insulin. The biggest barrier isn't medical, it's psychological. Patients hear daily injection for life, and they resist. Framing it as 1 injection a week is a different conversation. It lowers the barrier to starting insulin, and I think that could be its single biggest impact on outcomes. Bottom line, Icodec is a real advance for the right patient, but understand the pharmacokinetics. This is not glargine given less often. The sick day rules are different. The hypoglycemia recovery is slower, and steady state takes weeks. Pick your patients carefully. Okay, let's talk cardiovascular outcomes. This week in JAMA Cardiology, Stephen Nissen and colleagues from Cleveland Clinic published a post-hoc analysis from SURPASS-CVOT that I think deserves more attention than it's gotten. Quick recap of the parent trial for context. SURPASS-CVOT, published in the New England Journal last December, was a head-to-head of Tirzepatide versus dulaglutide in about 13,000 patients with type 2 diabetes and established atherosclerotic cardiovascular disease. This was an active comparator trial, not placebo-controlled, which is important because dulaglutide already has proven CV benefit from REWIND. The primary outcome, 3-point MACE, meaning cardiovascular death, MI, or stroke, occurred in 12.2% of the Tirzepatide group versus 13.1% of the dulaglutide group. Hazard ratio 0.92, confidence interval 0.83 to 1.01. Non-inferiority was met, p equals 0.003. Superiority was not, p equals 0.09. So the primary trial told us, Tirzepatide is at least as good as dulaglutide for cardiovascular protection. Not bad, but not exactly earth-shattering. This new post-hoc changes the picture. Nissen's group looked at a broader 6-component composite. all-cause mortality, MI, stroke, coronary revascularization, hospitalization for heart failure, and a composite kidney endpoint. In over 13,000 patients with nearly 4 years of follow-up, this composite occurred in 23.7% on Tirzepatide versus 27.4% on dulaglutide. That's a hazard ratio of 0.84, 95% confidence interval 0.79 to 0.90, p less than 0.0001. Let me do the math for you. The absolute risk difference is 3.7 percentage points. Over roughly 4 years, that gives you a number needed to treat of about 27, meaning you'd need to treat 27 patients with Tirzepatide instead of dulaglutide for 4 years to prevent one major cardiorenal event. And remember, you're comparing against a drug that already works. That's an NNT against an active control. That's impressive. The sensitivity analyses were consistent. 5-component composite without kidneys, HR 0.86. 4-component without kidneys or heart failure, HR 0.86. The signal was driven not by one component but spread across the composite, which makes it more plausible than if it were hanging on a single endpoint. Now, I want to be methodologically honest here. This is a post-hoc analysis of a trial that was designed for a different primary endpoint. Post-hoc means hypothesis generating, not confirmatory. We should not treat this the same way we treat a prospectively powered outcome. But the consistency across sensitivity analyses and the biologic plausibility, Tirzepatide produces substantially more weight loss, more insulin sensitization, more triglyceride reduction than dulaglutide, make this a credible signal. And here's my practical take. If I have a patient sitting across from me, type 2 diabetes, prior MI, eGFR 55, BMI 34, hemoglobin A1C 8.2, and I'm choosing between a GLP-1 RA and a dual agonist, this post-hoc gives me another reason to lean toward Tirzepatide. Not definitive evidence, but the direction of the data is clear and consistent. The 0.92 hazard ratio for 3-point MACE with a p of 0.09 for superiority has always nagged at me. With 800 odd events per group, they were close. Another 6 months or a few hundred more patients might have gotten them there. I suspect Lilly is thinking hard about whether to run a dedicated cardiovascular superiority trial with a broader composite as the primary endpoint. Bottom line, this is one of the more compelling post-hoc analyses I've seen recently. An NNT of 27 over 4 years against an active cardioprotective comparator is meaningful. If you're already using Tirzepatide for glucose and weight, the cardiorenal data are trending strongly in its favor. If you're still defaulting to single mechanism GLP-1 RAs for your high-risk patients, this is worth reconsidering. Quicker take. The AACE published its 2026 consensus algorithm for type 2 diabetes management on March 17th, led by Susan Sampson and Priyatama Velanki. It's reorganized into 11 sections and makes 3 moves I think are worth noting. First, the shift to a complications and comorbidities-centric approach for medication selection. Don't start with hemoglobin A1C and work backward. Start with the patient's cardiovascular risk, kidney function, weight, liver status, and let that drive the drug choice. If they have ASCVD, a GLP-1 RA or dual agonist with proven cardiovascular benefit goes first. Heart failure or CKD, SGLT2 inhibitor first. This is consistent with what ADA EASD and the ADA standards of care have been saying. Good. Second, a new classification algorithm. This is a nod to the reality that not everyone with adult-onset hyperglycemia has garden-variety type 2 diabetes. They're now explicitly recommending that clinicians consider GAD65 antibodies, C-peptide, and in some cases, genetic testing. How many of you have seen a patient misdiagnosed as type 2 who turned out to have LADA and was deteriorating on a sulfonylurea because nobody checked antibodies? I've seen it too many times. This part of the update is overdue and welcome. Third, updated pharmacotherapy tables that include Tirzepatide, multiple Semaglutide doses, and Orforglipron. My concern? Implementation. 11 sections. Multiple decision trees. This is comprehensive, but it's complex. The vast majority of type 2 diabetes worldwide is managed in primary care with 15-minute visits. What these clinicians need is a 1-page flowchart they can tape to their wall, and to their credit, AACE usually produces one. So let's see. Bottom line, read the AACE update especially the classification algorithm and insulin titration sections. The direction is right. Whether it changes prescribing behavior in the real world, that's the question. Last story, and I saved it for last because I think it's genuinely important. Published this month in Brain and Behavior, Raza and colleagues performed a meta-analysis of GLP-1 receptor agonists in Parkinson's disease. 5 randomized controlled trials, 708 patients. And the answer is no statistically significant benefit on the primary motor outcome. The background matters. There was real preclinical excitement here. GLP-1 receptors are expressed in the substantia nigra. In animal models of Parkinsonism, exenatide and lixisenatide showed neuroprotective effects, reduced alpha-synuclein aggregation, less microglial activation, preserved dopaminergic neurons. And in 2017, the UCL exenatide trial by Athoda showed a 3.5-point improvement on the MDS-UPDRS Part 3 motor score. That generated a ton of buzz. But here's what 5 pooled RCTs show. Off medication, the MDS-UPDRS Part 3 mean difference was minus 2.0 points. Confidence interval minus 4.12 to plus 0.11, p equals 0.06. On medication, minus 1.4 points, not significant. No benefit on any secondary outcome. Part 1, Part 2, Part 4, PDQ. 39 quality of life, non-motor symptoms. Now, some people will look at that p of 0.06 and say trend toward benefit. And I get the temptation. But let me push back. The MDS-UPDRS Part 3 goes from 0 to 132. The minimal clinically important difference is usually pegged at about 3.25 points. A 2-point improvement that doesn't even reach statistical significance is not a clinical signal. And with 708 patients across 5 trials, if there were a meaningful neuroprotective effect, we'd expect to see it. Meanwhile, the adverse events were significant. Nausea was doubled. Risk ratio 2.09. Vomiting was 4.5 times higher. Risk ratio 4.53. Constipation was up 60%. And keep in mind, many Parkinson's patients already have severe autonomic GI dysfunction, gastroparesis, constipation, dysphagia. Adding a drug that makes GI symptoms meaningfully worse with no demonstrated motor benefit is a tough sell. And this matters for us as endocrinologists because our patients are reading headlines that say GLP-1 drugs cure everything: Alzheimer's, addiction, cancer, Parkinson's, and some of those signals, cardiovascular protection, kidney protection, MASH improvement, are backed by hard RCT evidence. But neurodegeneration is not yet. So if a colleague or a patient asks you, "My father has Parkinson's, should he go on Ozempic?" the honest answer right now is, we have 5 randomized trials, 708 patients, and no significant benefit. If he has diabetes or obesity, prescribe the drug for those indications, but don't prescribe it for neuroprotection. The data aren't there. Bottom line, GLP-1 receptor agonists are remarkable drugs, but they're not a cure for every disease that has inflammation in its pathophysiology. This meta-analysis is a healthy reality check. That's your week in diabetes and endocrinology from Hormone Insight. If you found this useful, share it with a colleague. And if you disagree with anything I've said, I hope you do, because that's how we get better. You can find show notes with all the references at hormoneinsight.com. Until next Thursday, keep questioning the evidence, keep learning, and keep putting your patients first. Thank you for listening.